you very much, Tony, and really interesting to hear about the foundation and your ambitions for it. Be kind, care for each other. I mean, that's the fundamental, necessity if we're going to actually develop empathy for our patients, isn't it? That we actually have to have that capacity of empathy for each other first. And I'm going to talk about mental health and about empathy, but I'm going to talk about it by thinking about it from the perspective of people with learning disabilities. And I'm going to show you quite a few pictures and tell you a few stories. But I thought I might just start by telling you what I was doing this time last night. Because I sit in the House of Lords, I'm a crossbench peer, and it's a kind of voluntary job, except that sometimes it means staying quite late in the evening. I got home at midnight last night. And what I was doing was contributing to a bill which is going through Parliament, which is about data protection. But I was trying to change some of the provisions that are allowed within this bill for journalists. Okay? Now, you might think there's not much to do with mental health, but I'm going to tell you a story as to why. And it's to do with the kind of environment that we live in. Okay, I'm a psychiatrist. I don't know what that conjures up in your minds. Maybe you think that means I'm a pill pusher. We know that the number of prescriptions for antidepressants just keeps going up and up and up, right? But why? And is that really the answer when it comes to thinking about our mental health? I'm one of those doctors who thinks that medicine now needs to be very different from medicine as it was 100 years ago. I think medicine needs to be very different from what it was 50 years ago across the whole spectrum of specialisms. Right? And I happen to think that medication is usually not the answer. For some people, it is going to be important. So there's something about the environment and about what has happened in your life which is going to impact on your mental health. Of course, we all have mental health. We just hope that our mental health is going to be good. And sometimes our mental health is put under considerable stress, often because of traumatic things that happen in our lives. I've had quite a few traumatic things happen in my life, and one of them, I'm not going to tell you the details of it, but one of them was that after something difficult had happened, our family's privacy was invaded by the media in a very dramatic way over many, many months. Okay? It was at the time when phone hacking was kind of identified and discovered. We must have been phone hacked. We don't have the evidence for it, apart from how did people know what they knew. It's quite possible that people blagged, if you know what blagging is, that they stole private personal data in other kinds of ways. Okay? So the people who are opposing my amendments last night were not in the least bit concerned about the impact of stories told in the media, which might have a harmful effect on the people who are the subject of the story. So in frustration, I told them 2 or 3 stories. I'm going to tell you one of the stories that I told them last night. And it was because they were trying to argue that since the Leveson inquiry, which you will remember, do you remember the Leveson inquiry? Do you remember Millie Dowler, right? I mean, imagine being, a member of Millie's family and having that story, having what happened with Millie all over the papers, right? Her name bandied around, her voicemails intercepted by the media, the police knowing about it and doing nothing, not telling the family, okay? All of those kinds of things. None of the people who were speaking and opposing my amendment made any indication that they felt that what had gone on was wrong, right? And they said, well, anyway, all that was in the past because they now know that they should that won't happen. So I produced 3 examples of recent front page stories which have not been properly corrected. So one story I think is particularly relevant for nurses, because I think you'll understand it, those of you who are. So the story was a lady who was very overweight, and she lost over a period of time a huge amount of weight. And it was a real success story, a wonderful story. So she agreed to her story being told in her local newspaper to encourage others. And it was told, the story as it was, that she had lost a lot of weight and how well she felt. And she happened to say, for 20 years I couldn't get in the bath, so I had to shower. And it's rather nice to be able to get back in the bath, okay? So a national newspaper told the story slightly differently. They picked up the story and the headline was, let's see if I can remember it, "Grubby Gran didn't bath for 20 years." Okay? Now, supposing you were that lady, how would you feel to have that headline in a national newspaper about you? Do you think you'd still manage to keep your weight loss off? Or do you think you might despair? And I think it actually would probably have sent me back on the food. Do you know? These are some of the unkindnesses that happen in our lives, which is why being kind to each other and caring for each other really matters. Okay? So, and being kind to people who work in the NHS and in social care is really important too. Last week I came to a dinner here, and it was lovely because I met lots of nurses. And there was a nurse who's a recent graduate. She's a mature graduate because she started nursing and then left nursing and did lots of other things, had a family, but decided she really wanted to be a nurse. Are you here, Francesca? Is Francesca here tonight? No, she's not. Okay. She stood up and gave a wonderful talk during dinner. And she talked about, she quoted something that John F. Kennedy had said. Basically, don't curse the dark, light a candle. And I thought that was a really good place to really start tonight, to think about darkness, you know, the metaphor for ignorance, but how the role of mental health nursing is about lighting a candle, giving people hope. There's somebody else who gives a lot of hope, and I really enjoy this quote. So Pope Francis, in his talk on World Communications Day last year, gave this beautiful description of listening. He said, listening means paying attention, wanting to understand, to value, to respect, and to ponder what the other person says. Knowing how to listen is a gift which we need to ask for and then make every effort to practice. There's a lot in there. For people who work with mothers and babies, you may be familiar with the Wait, Watch and Wonder programme. Does anybody know it? Wait, Watch and Wonder? It's a beautiful programme, and it's, again, about listening. It's about waiting, about learning to listen, not just to words, but to the non-verbal communications, the communications that might indicate pain or anxiety. Things like the sounds that people make, their body language, the gestures, the facial gestures they make, and other non-verbal signs. My son has a learning disability, and he's also autistic. When he's anxious, he touches his nose. The one or two other things that he does that we recognise as a family are an indication that he's feeling really stressed. Okay? Really important to know that about him. So when you're with somebody, whoever it is, and I'm not just talking here about people with learning disabilities, I'm not just talking about children. I could be talking about somebody with dementia. We could just be talking about, you know, somebody in your family whose behaviour may have just changed a little. I was talking at a dinner yesterday to a GP, a couple of days ago, to a GP, senior GP, who said, today we still diagnose certain conditions just the same way they were diagnosed 200 years ago. He said, we haven't yet learnt to document the little tiny changes in behaviour, the way we feel about ourselves, in such a way that we use modern technology to help us to analyse what those changes are. And the example he gave, I thought it was lovely. He said it's the itchy nose and the wriggly toe. We might discover that having an itchy toe and an itchy nose and a wriggly toe is one of the first signs of, I don't know, dementia or cancer or something. But we're not collecting the data. And we're just leaving it to, we go to the doctor and we say, oh, well, I've been bleeding, doctor. It's a bit embarrassing. And you see, it's, you know, it's down below and I've lost quite a lot of weight. And the doctor's going to immediately think, aha, a light goes on. I know what that is, okay? The patient probably knows as well, right? But what about the itchy nose and the wriggly toe? Do you see what I mean? There are other things that we could be doing now. I'm just saying that actually in mental health nursing and in psychiatry, there's quite a lot of skill that one develops, which is about noticing, wondering if any changes in behaviour indicate an illness that may not be attributable to their disability. So if you take somebody with a learning disability, typically, you know, me as a mum or, you know, somebody else goes along to the doctor, perhaps somebody with a support worker, and the doctor reassuringly says, well, he's got a learning disability. We call it diagnostic overshadowing. The actual, you know, condition may be overlooked because the learning disability is seen as the cause of whatever has happened, the behaviour, the other symptom. There's a story of my son where he went to the doctor, the GP, and he said that his hands were getting smaller. Okay? And the doctor thought that this was a psychiatric condition. It turned out that he'd got a terribly high fever and he was delusional. You know, it's actually really, really important not to confuse different things. So, for a lot of the people that I used to work with when I was clinically practicing, thinking about how to gain their consent without using any words. Often it is said of somebody, well, they wouldn't be able to give consent. Clinicians have to be really, really creative and thoughtful about that. And sometimes it's important just to adjust the environment that the person's in to support their access, their comfort, and their safety. So, and I could give you lots of examples of that, but every year I actually believe in flu jabs. I'm not quite sure why, but I always have one. And I always encourage my son to have one too. He doesn't really like injections. We went along to have it, and he was going to see a nurse he normally sees. And the nurse was off sick, so he was to see a locum doctor, and I think she might have been a trainee. And she clearly was completely fazed by meeting somebody like my son. She'd never met him before, so she was being quite officious, you know, sit down, roll up your arm and whatever. Well, he'd brought a puppet with him, and he needed to have time to set the puppet on the side. And I said, he's a middle-aged man. Sit the puppet on the side, have the puppet smiling at him, so that he could be mindful with the puppet in order to have the injection, okay? Because then he'd be able to concentrate on the puppet, and puppets are very reassuring to him. It's kind of sometimes a bit embarrassing going through airport screening with him, because normally people don't know that he carries one with him, in case he's in a very anxiety-provoking situation and he wants something familiar with him. Children do it all the time. Some adults do it too. Many adults are comforted by having their iPhone with them. Yeah? You know, don't you get anxious when you wonder where it is? You know, he's fine if he's got this in his bag. Normally he doesn't need to take it out. Okay. Now, there is a problem, which is that a lot of people with learning disabilities and people with autism have been given medication to manage difficult behaviour because it's just seemed like the right thing to do to help people with their anxiety. And there's a project at the moment called STOMP, stopping over medication of people with learning disabilities and autism. And it's a really difficult campaign because there's no evidence that giving somebody medication because they get anxious, because they lose their temper, because they don't feel understood, because they're kind of taking quite a lot of patience to be with them. Medication is not really, I mean, I think it's a human justice issue, but people with learning disabilities are far too many taking medication that they shouldn't be taking. Really, really difficult to reduce that medication once people are on it. And one of the reasons is because carers, once somebody's on medication, are terrified that if the medication is stopped, somebody might become more difficult to support. I did a piece of work with Health Education England looking at the workforce in both health and social care. And I think nurses can work in both health and social care, although the profession which probably transcends that barrier most easily are occupational therapists who are trained really to work right the way across. And of course, occupational therapists work very closely often with nurses. But we're trying to move away from a hospital setting, we're trying to move away into a community setting. And yet, it's kind of quite difficult to make that transition. And so I usually, I don't think I've got it on this slide presentation, have just a picture where it's a triangle, and you can have the triangle either way up. But if you have the triangle with the point at the bottom, and you imagine that the person with mental health problems in a mental health crisis is at that point, but all the staff are up at the top in the tertiary treatment centres, the assessment and treatment units, and there isn't really anybody who knows them and has specialist skill and can help them to stay at home. They're likely to end up being admitted into a hospital under a section of the Mental Health Act and find it really, really difficult to get back home again. Okay? There have been a few scandals. You may have seen the Panorama programme about Winterbourne View Hospital. And there's been a big programme of trying to change care and to move people into the community. It's only going to happen when health professionals begin to really understand that being in a nice, sparkly assessment and treatment unit is probably not really the place, the cool place to be. The cool place to be is at the sharp end. And we turn the triangle round so that actually the point is at the top. And there are very few people in assessment and treatment units because actually the nurses and the OTs, and dare I say it, the doctors and the psychologists are all working where people are living, understanding what their actual needs are. Okay. So, informing people who may have difficulty understanding information may require providing accessible health information. And a lot of people really have difficulty decoding words and pictures, especially if they're given together. Some people actually find pictures easier than words. Some people find words easier than pictures, usually people who are very clever, have had a university education and enjoy reading very long, complicated books and perhaps have forgotten how to look at pictures, okay? But if you have never been a very wordy kind of person, then looking at pictures is probably quite good. And there's quite a lot of evidence for it. I don't have time tonight to give you the evidence, so I'll just give you one, which was Hibbing and Rankin Erickson's review of the literature, where they found that supporting understanding through pictures did in fact resolve difficulties decoding words. And they did this by activating the background knowledge and reflecting and making predictions about what might happen. So a single channel of communication enhances both emotional, and this is really, really important. Information isn't just factual, both emotional and factual understanding. And what I'm going to demonstrate to you is how picture narrative is easier to process than illustrated written information, sometimes called easy read, or auditory or written information, and especially any of those modalities used together. Okay. So, I'm just going back to the House of Lords for a minute, because I felt that I could have retired in 2012 because I achieved a change to the Health and Social Care Act. And all it was 3 words that I added in, and it was, instead of having health and illness as being what it was all about, it said mental and physical health and mental and physical illness. And the reason I did that was because I went around the House of Lords and I asked people if they could give me an example of an illness. And I asked about 25 people, and not a single one mentioned any mental illness at all. They had a long list of physical conditions, but not a single one mentioned a mental illness. And so although the minister thought that health and illness, everybody knows that it includes both, in fact it didn't. And so that's now called parity. So mental and physical health people are talking much more about and are much more aware of the fact that they are interconnected. And I sometimes used to say to medical students, have you noticed that your heart and your brain are in the same body? And would it be surprising if they kind of affected each other? You know, sometimes these very simple concepts are really kind of helpful in changing this notion that somehow mental illness is over there and is separate from physical illness, which is over here. We're finding more and more that some people will present their health problems in a physical way, and some people present them in a psychiatric way, or with symptoms of mental illness. But actually, there's bound to be some sort of connection between them. And that's not to say that there aren't some illnesses, specific illnesses, of course there are. So it's harder to listen, it's harder to be empathic and to listen, and it's harder to do it than to prescribe. And I started my medical career as a GP, and I used to get told off by the senior partner because he said, you're taking too long with your patients. You haven't got time to listen to them. You should, if you're worried about them, send them to the accident emergency department. But we're on one patient every 5 minutes, and on Monday evening it was double booked. So things have improved, they really have. They have changed. But I found that very unsatisfying, and I certainly didn't find it satisfying that I was expected simply to write a prescription. And you don't have time to think about what the right prescription is. So I used to prescribe something fairly meaningless. So beyond words. So this is some work that I began in the late 80s, and it came out of some work in a long-stay hospital where I'd been working with I was asked to go and see a man who had refused to get up in the morning. He didn't have any speech. He had Down syndrome. He was 40 years old. He was called John. And I remember him well. And the nursing staff said, could I prescribe something for John? Because he wasn't eating. And he was actually beginning to self-injure. They were worried about his eyesight. But they couldn't tell me what had changed. I asked about why this behaviour had happened. They didn't know. I asked, they couldn't find an explanation about what had changed. But a member of the kitchen staff was able to tell me that John's dad used to visit every Sunday, and they hadn't seen him for a while. Okay, so I diagnosed a bereavement reaction. But he couldn't speak, and people thought that he wouldn't understand. And I created my first book. I've got a copy here if anybody wants to see it, called When Dad Died. Because I couldn't find any other way of explaining to this man that his father had died. There was no other resource. There was an assumption that he wouldn't understand. And so that's the first book that I did. And it led on to quite a lot of work. Now, this is a little video which should have sound. Should I go back to the beginning?
Doctors are usually pushed for time, so they've got to get in, explain the procedure as quickly as possible, but in doing that sometimes muddling the patient. The book takes it in stages, how to approach a patient, how to explain something, depending on the procedure being explained. So like taking one's blood pressure, for example. There's one book where you could use for that particular procedure. Giving the patient a book means that for that moment in time, the patient has the ownership of the book. And it's quite self-explanatory in the book on what's going on, and the patient can actually follow what's going on just looking at the book.
It made me feel reassured. When you see the picture, you know it's something you do on an everyday basis, don't you? Take people's blood pressures, temperatures.
The nurse showed a book of pictures of what they're going to do before they start the proceedings. They'd be helpful for people that are nervous and they don't want to stay in hospital on it.
I think taking Claire's temperature went quite well. Because I was able to show her the book beforehand, she could tell me what she already knew about taking temperature, so she was already quite familiar with the process, which was good, and she could talk me through it, which I think made her feel maybe a bit more in control of the situation.
I found it a lot easier than normal due to having books beyond words, because normally I find it difficult to explain what I'm going to do. There's quite a lot of long words. If I was going to access book beyond words in my practice, I think I'd use my app, because you've got all of the different scenarios on there.
Several of the nurses have iPads. I think if they had that on there, it would just be an app that they could access pretty quickly and take it to any situation they're in, so it can be so effective for those with complex.
So Gary there, who has a learning disability and who was teaching student nurses at St George's, was basically, he teaches, or was teaching, I think he's no longer teaching at George's, he taught there for about 15 years, was teaching essentially communication skills both to medical students and to nursing students. But in this particular session, he was teaching them how they could use pictures to help them in their clinical practice, to help them to communicate with a patient who might not understand very well. Jackie on the right was one of the first people who I employed at St George's as a woman with a learning disability to teach students. Jackie can't read or write, and she always needed some help to find a way around St George's, but she's one of the most intuitive and empathic people I know in terms of being able to put her finger on exactly what it is that the audience wanted to or needed to know, and her work with students was phenomenal. And so being taught by people who themselves have the difficulties that you need to learn to work with and accommodate can be really, really helpful. And I think possibly one of the only ways that you can really begin to understand the needs of this particular population. I've always said that if you could get it right for people with learning disabilities, you could probably get it right for everybody. We tend to do it the other way around. We tend to get it right for people like us, right? That's the problem. There is a risk that we are more comfortable with people who we perceive as more like ourselves. And we should actually really, as you know, within the health professions, be trying to become, really moving out of our comfort zone right at the beginning of our professional careers, and being able to be comfortable with people who have had very different life experiences, potentially to our own. So I want to now tell you and give you an opportunity to experience pictures for yourself and to see whether or not you're a visually literate person, whether you can tell a story in pictures, and how you feel about pursuing a story which is relational, which includes some trauma in it. You can tell that from the title. The story does end with hope, but I'm not going to share the whole story with you, so I don't think you'll see the whole of it today. It's a story with quite a lot of emotion in it. Now, sometimes I would read this story with my son standing here. In fact, I'd get him to do the reading because he was mugged, and some of this is actually about some of his experience. But when we published this book, we had several parents and others contact us and say, how did you know my son's story, my daughter's story? These books are not just used clinically, they're also read in book clubs. And in book clubs, when they read this story, there will be several people there, people with learning disabilities, who themselves have had an experience, a scary experience of being exploited and assaulted. Okay? So some difficult images coming from one person's story, but being relevant to so many other people's stories, but also ending with some examples about, one, how you can keep yourself safe, but how you can have hope for the future. Okay? Now, I'll start you off. Okay, so I'm going to call him Charlie, and he's our hero in the story. And he looks as if he's in a cafe, and he's got a card, so it looks as if, doesn't look as if it's his card. Maybe he's bought the card for somebody else, and his friend's having something to eat. He looks kind of quite buoyant, doesn't he? So what's happening here? He's got a mobile phone. There's some guys at the back who look a bit shifty. I wonder what they're up to. So the envelope still doesn't have a name on it. He's leaving with his friend. Those other guys are following. I'm beginning to feel a bit uncomfortable. Ah, they've stopped to say hello. Okay. All standing at a bus stop together. Oops, Charlie's friend Dave's getting on the bus, but the others aren't. I'm going to let you use your imagination from now on. Okay, so what happens in the story is that, I feel really mean now. What happens in the story now is that Charlie goes home, and he doesn't want to go out, and he sits at home, and he's got a plaster on his face, and his mum's being very supportive, but he really doesn't want to go out, and his friend comes around, and he doesn't want to go out, and then somebody from victim support or some other organisation comes to see him, maybe a counsellor. But then time passes and he does go out. But when he goes out this time, he goes with his friend, and they face a few challenges on the way to the place they're going. Somebody stops and offers them a lift because it's raining, and they say no. Some children stop and try to ask them for money, and they say no. Anyway, they arrive where they're going, and they've arrived at a group. It doesn't really matter what the group is. It could be their book club, it could be a sports club, or some kind of event. It might be group therapy. It doesn't really matter. That's the beauty of pictures. They arrive, and you see him telling his friends about how they manage the journey and how proud he feels of the fact that he's actually getting out and about again and has learnt a few things along the way. But the question I wanted to ask was about Charlie's healthcare, and what barriers might he have faced when he arrived at the hospital. So imagine that he's quite shocked, he's been hurt, maybe seriously, maybe he's going to need surgery to his face. But he arrives and he's probably very scared and not able to talk, you know, and he's dirty. He can't explain what happened. Nobody knows what happened. Nobody saw it happen. The police picked him up, but he's, you know, how is he going to explain? And what barriers would he have faced? Well, probably quite a lot. These are some of the barriers that some patients experience. People not listening to them, maybe. Perhaps not being very clear, using long words, just the fact of them being strangers, being asked questions that they can't answer, like, what time was it? Or being asked the same question several times because the questioner doesn't wait 10 minutes for you to process the question and be able to answer. Just the complexity of it. But the strangeness of the environment is likely to be a very big one. Okay? So I've already talked about diagnostic overshadowing, and I'm going to move on. One of the consequences of a reduced access to good health care for people with learning disabilities is that they have a higher rate of avoidable and premature mortality than the rest of the population. So men with learning disabilities, in the most recent study, die 13 years earlier than other members of the population, and women die a staggering 20 years earlier. Okay? There's no good reason for that. There's no particular reason why you would die earlier. There are some medical conditions that are more associated with some kinds of forms of learning disability. So, for example, testicular cancer is more common in men with young men with Down syndrome. Okay, that's not going to account for that. I did a study back in the late 1998, I think it says, and my study found that people were, one, they died very early. I think in my study it was something like you were 58 times more likely to die before the age of 50 than the rest of the population. But the majority died of respiratory disease. Now, in the general community, only 15% of people die of respiratory disease. And it's probably less than that now because far fewer people smoke. People with learning disabilities tend not to smoke. So that's not a risk factor, okay? Although passive smoking, I guess, might be. So 50%. And I concluded back then that it was probably due to kind of discriminatory attitudes within the NHS. Or, maybe I thought it could be a failure of people to seek investigation and treatment. The confidential inquiry for looking into premature mortality for people with learning disabilities has found that they think it's a discriminatory attitude, but they found that what happens is that people don't present any later to the doctor, but they have fewer investigations and less treatment. Okay? And why would that be? Okay? Why would that be? Has it got something to do with empathy? Is it discriminatory? It's going to be complex, that's for sure. And so the National Mortality Review is now looking to try to understand exactly what happens when somebody dies an avoidable death, and to try to understand what those factors are and to feed it back into the service system. So people also have much higher rates of adjustment disorders, anxiety and depression. And this is quite problematic. People also, in that mix, will have higher rates of post-traumatic stress disorder. And there's a real difficulty here because our NHS today relies very heavily on what the NICE guidelines say they must do. And sometimes those NICE guidelines will say that there wasn't any research on applying this particular treatment to people with learning disabilities. And people will assume that therefore means that they're not going to be eligible for it or wouldn't benefit from it. Okay? So there's too little research. There's too little research in mental health. There's also much too little research in learning disability. So my argument is that the relational aspect of the clinical patient encounter and treating every patient with respect is the fundamental skill that every clinician needs. And that's what empathy is about. I don't know whether you can see this slide. Don't worry if you can't. I'll just explain it. In 2016, Jeffrey published a paper in the Journal for the Royal Society of Medicine in which he spelt out the 5 features of empathy. And they were connection, clinical curiosity, an emotional empathy. It was described as the other-oriented perspective, and then a behavioural and cognitive empathy, and a behavioural and moral empathy. And the behavioural and moral empathy is called care. Right? So I've been looking at that in connection with my Beyond Words approach. So in terms of a relational connection, the emotional and behavioural empathy, I would argue that reading together, reading a book, listening to somebody's reading of a book in pictures, recognises and communicates feelings. That clinical curiosity or insight and cognitive empathy really needs a tool for the doctor or the nurse to help them to listen and observe. That to avoid dehumanization, to have an emotional empathy, you need something which helps you to empower the person to share their concerns. And if we think about a behavioural and cognitive empathy, we need the patient to set the pace and to decide on the agenda in order that the doctor or the nurse can understand the patient's context and respect their difference. And when we come to care, that the person feels respected, trusts the clinician, and engages in decisions. And empathy then maintains the clinician's motivation, but with an improved diagnosis and better clinical outcome. And this is the sort of research agenda that I think may be very important. So here we have some empathy in action. There's some reading, some listening. And in Beyond Words, this picture comes from a book about epilepsy. So the clinician might find it useful to be able to find out how much a patient understands. A picture might support somebody to make a decision and empower them. Now compare these two pictures. So, gentleman on the left in the picture, and the lady on the right. And the lady on the right is holding the book, and she's essentially the clinician in this encounter, and the man on the left is somebody with a learning disability. How do you think the man on the left feels when he's holding the book compared with when she was holding the book? And if I tell you a story that in training sessions when with nurses and doctors and social workers, we usually do a little exercise where we invite everybody to pick up a book and to read it together. And one of them is to have a learning disability, one of them is to be the clinician. And every single time, the clinician, the social worker, the supporter picks up the book and turns the pages and reads it to the person. And without being judgmental, actually after 5 minutes, we would say, now, don't know who was holding the book, but could you just keep the same role, but give the book to the other person? And then the penny drops, because suddenly the person who is the disabled person is empowered, takes it at their pace, picks out the things that they want to talk about, drives the agenda, communicates. The whole situation ends in a very different place. Okay? So it's about watching and wondering and asking, about a character in the book, I wonder how she feels. Have you ever felt like that? What's happening there? They might be used to share test results, to explore feelings. In counselling. But then there are some subjects that just feel too difficult, such as sexual abuse or death and dying. And I met one of our book club facilitators a couple of weeks ago and asked him which books his book club. Now, he's a volunteer. He's a man who previously had had mental health problems. He's a volunteer in a library in Kent. He's been running his book club for 4 years now. They meet once a month. He's got a group of about 7 people who come. And he said, oh, and I imagined that there were, you know, that they'd read all of the books that they were going to read, but that there would be some books that would be too difficult. And he said, oh no, he said, we've read all of them, except, he said, for the ones about death and dying. He said, but that's me. He said, I don't think I could do that. The group might be able to, but that's not for me. I can't do death and dying. So I said, so sexual abuse, domestic violence, being in prison? Oh no, he says, we haven't had any problem with any of those. We've read all of those. They've read some fun ones as well. The books aren't all tough. You know, mugged, no problem. Jenny Speaks Out, no problem. A Day at the Beach, fine, great fun. Ginger is a Hero, a story about a cat. But he said the group, once they've formed, are able to tackle any subject that you might read in your book club, where you're reading about tragedy, you know, redemption, whatever else. So exploring difficult subjects, enabling a disclosure, and sometimes these things come out at most unexpected moments. So my son sometimes helps with teaching, and he was teaching, well, helping run some groups for teachers. There were 40 teachers. They divided into a group after a little while. They read a book together. He was leading the discussion. And at the end, all the speakers and the people with learning disabilities who'd been co-facilitating came up on the stage for a panel. And I said to them, so, Nigel and Jackie, it's a long time since you were at school. Thinking about school, would pictures have helped you? So Jackie said, well, my mum died when I was at school, and if we'd had when mum died, it would have really helped because nobody talked to me about my mum. And my son said, when I was a little boy, he said, I was at Queen's Mill School and I couldn't talk. And he said, I must have been very naughty because the teacher used to put red soap in my mouth. Do teachers still do that today? He said. Now, I've never heard this story before. I knew that that teacher used to do that because another child who could talk had come home and told his mum, and I was a parent governor, and I got her sacked, okay? It took quite a bit of doing. But he couldn't talk, and I didn't know it had happened to him, okay? But it was the very interesting way he just said, do teachers still do that today? And that's one of the things about something abusive happening, isn't it? That you imagine that it's normal, right? And this kind of thing, unfortunately, has been a bit too normal in the lives of people with disabilities. And I think what we're realizing in the mental health world now, rather belatedly, is just how much earlier trauma in people's lives can have a really serious impact on how people manage in adult life. Like anxiety conditions, inability to make relationships, all of those kinds of issues which can affect functioning adult relationships. Here's Katie, who's teaching in a group, and she runs a book club in her own house. And she now has just become an apprentice in a special school, an apprentice classroom assistant. Katie has Down syndrome. So many homeless people have mental health problems. There are quite a lot who will be illiterate, who can't read. And many people become homeless because of loss or trauma, but also are likely to experience further loss and trauma. And people with thought disorders or memory difficulties, people who don't speak English. And who are they going to read their books with? Well, they might read them on their own, but they might well read them with a nurse, with a peer, in a group, with a support worker, or in a community setting. So, some years ago, I used to create picture books as a product of research, because as an academic, one of the pieces of good practice is that when you publish an academic paper, you should also publish a professional paper, and you should also publish one for the general public, okay? So that you can disseminate your findings, you can disseminate good practice, you can explain what it is you've been doing with public money in developing your research ideas. It's part of being accountable, right? How could I communicate my findings about good practice in supporting somebody who'd been bereaved, or in supporting somebody who'd been abused, or in supporting somebody who'd been institutionalized, other than by using pictures? So my books were really part of my research output. And then when I retired from the university, I decided that it wasn't sufficient for them just to be used by psychiatrists and nurses, but that I needed to make them available to the community at large. And I actually think that trying to work directly with people in community settings is probably more valuable than anything I ever did as a clinical psychiatrist. Because it's actually trying to meet people where they're at. And so take this group. It's quite a large group. I think usually they now meet in 2 groups. But when they've got an issue, they will now invite somebody into the library to meet them. So we've got a book about losing weight, and quite a few of the group were overweight. And so a community nurse started going in every week to run a healthy eating group with this group of people who started by reading picture books. And so by creating a peer group, a support group, in a public place, open, one of these groups, one woman came, didn't want to join the group. So the group said, well, there's a chair here for you, but why didn't you sit over there and watch? She came for many months and sat and watched. And then one day, she came and just sat down in the chair that they'd kept for her. Okay? Sometimes people would come to a group and they don't feel ready to speak. There was one group that I worked with where this man came. He was escorted by a nurse to come. The first few weeks, he lay on the floor and cried. After 3 years, he was effectively acting as co-therapist in the group. Okay? So trying to be with people where they're at and helping them gradually feel like they belong. So many people with mental health problems don't feel that they belong. The trouble is, most people I found, most nurses, most doctors, most therapists have to learn how to read and how to listen. So it goes back to the quote I gave you at the beginning. Doesn't come intuitively. When you're a professional, you've been taught to be that you're an expert. You've got some expertise to share. Maybe you're the wise one who can tell people things, give them information, tell them what to do. Listening is kind of a bit counterintuitive. It's really difficult to learn to be, to watch, to wait, and to wonder. So we've been running training, and we're doing some work with 2 mental health trusts at the moment to try to help nurses in particular to learn how to use an app which has all the picture scenarios in it, which are searchable, so that they just might have a pictorial scene, scenario there in their pocket that they can pull out at the right moment because they have a patient who needs to be able to explain something to them, to be able to share something, or who needs to be prepared for something as simple as a blood test or having their blood pressure taken, or an anaesthetic. Okay? So I'm going to draw to a close, but just to say that there are many themes in what we've been doing in our sort of beyond words approach. Mental health and well-being is one of the bigger groups, but there is also criminal justice, and they come in different formats. But for people who've never had books, having a book is probably the most preferred format. And I'm going to end by acknowledging my son, because I wouldn't have done any of that, and I wouldn't have actually discovered how important it is that we sometimes step outside the obvious professional role we have to begin to be confident in using our professional expertise in relationship with a particular patient. Sometimes people are being encouraged to take a particular task-based approach to a clinical situation. In the United States, for a long time now, junior psychiatrists would be given 15-minute medication clinics, meds clinics. That's what they'd be expected to do. They'd be told, you're a doctor, you can't, you're not part of a team, you've just got to do the meds clinics. And that's what they'd be doing. And I was terrified that that would come to this country. I think it's coming to this country. I know that there are nurses who really welcome the opportunity to become prescribers. I think most doctors would love you to. People do not want to just be perceived as having a role which is a task such as prescribing medication. That's not what a doctor or a nurse is really about. It may be one of the tools in your toolkit. It may be something that you are going to need to do, but there's rather more to that clinical role, and our patients expect it, our public expects it, and we need to do it. I learned that because of my son. This is my son. Looks pretty handsome kind of guy. He's got a book club. The book he's holding is called Falling in Love. His book club happens this Saturday. He is in love at the moment. That's his favourite book at the moment. But if it hadn't been for spending the first 9 years of his life without him putting two words together, I don't think I would have learnt some of this that I've been able to share with you tonight. So just to say a big thank you to him. Thank you for listening.
Thank you very much.